So up next we have Frank Ambriz. He is the Program Director of Physician Assistant Studies at the University of Texas Rio Grande Valley and also serves as a clinical professor in the College of Health Professions. As the Program Director of Physician Assistant Studies, Mr. Ambriz has been recognized for the development and expansion of the program, included being awarded 2018 Outstanding Physician Assistant Educator of the Year by the Texas Academy of Physician Assistants. Mr. Ambriz received a bachelor degree in biology from Pan American University in 1977 and completed his Bachelor of Science degree in Healthcare Sciences and Physician Assistant Studies from the University of Texas Medical Branch-Galveston in 1979. He then completed his master's degree in Family and Urgent Care at the University of Nebraska Medical Center. Mr. Ambriz spent 10 years as a clinical assistant professor with the University of Texas Medical Branch, and in 1994 was appointed by Governor Ann Richards to the Texas State Board of Medical Examiner Physician Assistant Board. Please welcome Mr. Frank Ambriz. You can try that. Let's try it and see.
All right, can you guys hear me? Thank you. Well, that was a great introduction. I just wish my parents were alive to have heard that. Okay. But, you know, our parents pride on our success, right? As we as parents pride on our children's success. And that's why we're here. I'll tell you a couple of stories to get going. And I was just reminiscing that in my undergraduate school, I went to UTPA when it was University of Pan American. It wasn't UTPA, it was University of Pan American. And I remember that I didn't have a guide as to what I wanted to do. I knew I enjoyed science, and I went to a talk. They brought down this doctor from San Diego and talked about oceanography. And afterwards, I stayed behind and I talked to him, and I said, that's what I want to do. I want to go into oceanography and feed the world, right? That was my ambition. And one of my professors saw me and afterwards called me over and said, why do you want to go into oceanography? Why don't you consider healthcare, medicine? I go, all my friends are trying to get into medical school and they're not getting into medical school, so what are my chances of getting into medical school? And he said, well, consider the healthcare field. There's other choices. Consider the healthcare field. And I said, why healthcare? He said, because there will always be a need for sick people. And 40 years later, we're still in that dilemma. We need more healthcare providers. We need more. Our population is growing. They're growing older. And we need to focus more on paying attention to the elderly. I'm at that age that I need help from the students that I teach. And I tell my students, when you finish, you know, I want to get you the best education because you're going to be taking care of me down the road. And that is so true. And so the other thing I want to leave with you today before I get started is that we're in a transition of healthcare delivery. The type of healthcare delivery that we had 20 years ago is different than today, and it's going to be different in the future. The future of healthcare delivery is no longer going to a physician's office and having that physician do everything for you. The healthcare future transformation is teamwork, interprofessional healthcare teamwork. And the results of that are better healthcare outcomes. Here in the Valley, we're number one in obesity, number one in hypertension, number one in all cardiovascular disease, and number one in diabetes. We can do better, but we can't do it by one person alone, one physician alone. We need a teamwork. And in that teamwork is what I'm here to tell you today is an open field, the allied healthcare field. Allied healthcare field involves a lot of people. So the allied healthcare field will involve not only nurses, they will involve medical technology, they will involve EMTs, they will involve radiology techs, And not everybody can be a doctor, but they can be the best that they can. And in directing them to a healthcare field, they will be able to sustain a better economic life. The going rates, and I'll show you some salaries on healthcare, is better than what we can do. The minimum wage right now is what, a little over $7, $7.25 an hour. On an annual basis, that's a little over $14,000. Who can survive on $14,000? It's unbelievable that, you know, in Hidalgo County, the poverty rate is now raised from 30 to 40,000, family of four. I don't know how people can do it, not to live a lifestyle that we enjoy. Driving a nice car, living in a nice neighborhood, eh? But we can do it. And the best way to do it is through education. And that education is right now an open market for allied health. Okay? Allied health, by the definition of that, involves more than just being a physician. Technicians and clinicians are two parts of the allied health. A technician usually will need two years of education, and that can be accomplished at a community college or a South Texas college. And then the clinicians require some advanced training that will be a 4-year college degree and even beyond. And unfortunately, right now, we still group nurse practitioners and PAs under the rule of allied health. And slowly that's training into an advanced practice practitioner, a different role aside from just being an allied health. And that's the direction we're headed. Patient care involves dentists, involves dental hygienists, involves occupational therapy. We're now learning that part of the number one patients that have dental disease will go on to have cardiovascular disease. It's just unknown. We got to prevent it. And you have to encourage them to go to the dentist and get their dental checkups, even not only the children, but also the adults, to prevent what's happening down the road. Again, the job opportunities right now, 60% of the allied healthcare force is going to continue to grow. The Bureau of Labor estimates that this is probably one of the areas, the second area of growth and demand in the coming future, in the coming 10 years. We just mentioned the 2-year and 4-year kind of separation. This kind of illustrates all the other healthcare practitioners or partners that we should be aligning. We have here in South Texas the ACO concept. An ACO is an acute accountable care organization, and that was brought on by the term that we still use, Obamacare. And what that was is that we wanted to develop teams to have better outcomes. And the two organizations down here in the valley that are considered ACOs became the number one and the number two ACOs in the country. But they did it through a teamwork. Everybody that worked in that clinic became a team member, from the receptionist to the medical record clerk to the nurse to the PA, the NP, and then they brought in a dietitian. They brought in physical therapy. And so they developed a interprofessional collaboration that no longer is a physician the one that's developing a diet plan. Now we go to an expert that can do that better for us and has time to do it, so we can spend time in treating our patients better. And those ACOs save the government millions and millions of dollars. The concept was, for every dollar that you save Medicare and Medicaid, we're going to give you back 50 cents. The first ACO here in the valley consisted of about 13 doctors that got together and said, okay, what's going to happen is that when I see my patient and I need to refer to to another specialist, I'm going to give you all my records on that patient, so you don't have to repeat the labs, or you don't have to repeat the x-rays, and you don't have to repeat all the diagnostic testing. You just move on, review it, and move on. We save that money. So in the Valley, as you probably know or have heard, that the average cost for every patient that has Medicare, okay, to go see a doctor on an average, a year will spend $14,000, $14,000 of Medicare money. The average across the country, every Medicare patient is spending $7,000. We were spending twice as much. And the reason is because when I refer a Medicare patient to a specialist, they repeat everything. And then that person sends them to another specialist, and they repeat everything. And then by the time they get done, the patient's outcome is poor in that, oh, that patient had high cholesterol. Well, I thought the family physician was taking care of it. No, I thought the pulmonologist was going to take care of it. No, I thought the cardiologist was going to take care of it. At the end, the patient never got treated for their high cholesterol, causing more damage to their heart and lungs or arteries, and they wind up in the hospital. And so with the ACO concept, the doctors got together and they said, this is what we're going to do. The first ACO, after the first year, they looked at the record. They saved $22 million of Medicare. What does that respond to? I'm supposed to get 50 cents back on every dollar. The ACO got back $11 million. Those 13 doctors now have $11 million on their pocket. That's a lot of money. But they didn't do it alone. They did it with the concept of the team care. So everybody in the team had a little portion of that $11 million. So can you imagine, a doctor's take-home pay probably here in the Valley is about, I would say, $300,000 a year. With that take-home pay, they double their salary. They did less work. Everybody else now is pitching in and doing their part. So they all get rewarded. This is the concept of how we're transferring medicine. That group of 13 doctors, now everybody wants to join. Now they have, the second year they went up to 26. Now they got about 100 doctors saying, hey, I want in on this. How can you help me develop a better team? And that team involves not only the physician, but involves everybody that we need to get together here. Okay, let's talk a little bit about the salaries. At UTRGV, we do have some programs that we will prepare our students for occupational therapy. We're now getting the physical therapy program lined up, and it'll start probably in a year or two. We have speech therapists, we have dietitians, and we have rehabilitation counselors, social workers, athletic trainers, and clinical lab science, which is the medical technology group. Okay. And then the more advanced programs that we have here at the university involve the PA program and the nurse practitioner program. Sometimes it's really hard to get into those programs. The PA program, which I'm the head of, and I'll speak a little bit about that, is the #1 program in the country. Believe it or not, we're the best kept secret. We get about 2,000 applications from across the country for 50 slots. We just went up to 100. But before, 2,000 applications for 50 slots. So we take the cream of the cream. Last couple of weeks back, the admissions committee gave me the list of the first 80 that we selected from, that we're selecting 100, the first 80. The GPA of the lowest person admitted is 3.8. Very competitive. Very competitive. Our students here locally cannot compete at that level because they go to work, they go to school, they take care of family, and their GPAs may suffer. But you cannot tell me somebody with a 3.2 is going to be better than somebody with a 3.8. Okay? So we're developing programs to look at our local talent, bring them in, coach them, mentor them while they're in the program. It's the toughest program. It's 4 years of medical school in a 2-year curriculum. It's fast and furious. We get graduates from Harvard. We get graduates from Stanford. After their first semester, they're on scholastic probation. So I call them in. What's the matter? I mean, you went to a great school. It's the overwhelming amount of information that they cannot process. So we have methods of helping them process that information. So sometimes it does take that one semester of being on scholastic probation to get a fire under your feet to get going. But that's reality. Okay? So you guys are out there seeing students. Some of them will have that potential to go that far. Some of them may not have that potential. But we try, when we look at a holistic review, if they're already in a healthcare field and they want to advance, that's a pretty good student that's going to succeed in our program. We see a lot of medical technologists that come to our program, physical therapists that come through our program, pharmacy techs that come through our program, and that's what we're looking for as well. The demand, as we said before, is out there. The demand, the jobs or opportunity are there. Again, I'll state again that the Bureau of Labor here in the United States says that in the next couple of years, the growth is about 18% growth. So the jobs are going to be there. The jobs are in demand. The top 5 jobs in the next few years include occupational therapy assistants, physical therapy assistants, audiologists, hearing specialists, speech pathology. Others, let's just look at some salaries. A medical assistant, the average should be about $24,000. That's still a little bit of what the intent of the new administration wants to have minimum wage of $15 an hour. $15 an hour averages out to about a little over $30,000 a year. So it's getting better because we said $750 is going to run you about $15,000 a year. That's a little bit better than what is going on in the market right now. But you get students into the allied healthcare, there's a promise that they're going to give better than minimum wage. A cardiovascular technology person, we only have a few of those in need down here. Mostly the bigger cities have that. It's almost 38,000, a little over 38. Diagnostic sonographers are 52. We have programs down here to have our students go through. And there are 2-year programs. They'll be out, and there's a need for so many of those. There's even in outpatient, there's a lot of doctors now that are doing sonography. We are starting to teach sonography in our program to our students. A respiratory therapist, 43,000. Athletic trainers, 33. Surgical techs, 34. These are all good. The upper ones are the clinical practitioners that we still talk about in the allied health field. And those are the PAs, the nurse practitioners, and even the clinical lab science people. Those are pretty good salaries. And what I want to finish is that when you talk to your students about going into a career, help them move in the direction of healthcare. There is a job opportunity for them that's going to be better than maybe their parents. My parents grew up working in the canning factories, working the fields. We migrated to California to pick grapes and the fruit. And we were discriminated upon. At that time, I was only 6, 7. I didn't know what it was. But I remember going into a restaurant and being kicked out because I was Hispanic. And going, Mommy, why are we not eating? And they said, because the sign says no Hispanics are allowed in here. I didn't know better, you know. But we went through it back in those days. Our children deserve better. Our children deserve an education. Our children deserve to have better lives than we had. Are there any questions? What is the difference between a PA and an NP? Mostly it's education. The NPs have a nursing background, and they're taught mostly in the nursing caring of the patient. The PAs follow the medical model. So they have a lot of basic science. They have a lot of clinical science. And so when you do the comparison, there's a lot more education that goes into a PA. Now, when both of them finish, they're both doing the same job, basically. I work with NPs, and I can tell you there's some good and some bad. I work with PAs, there's some good and some bad. And I remember one time they brought in a nurse practitioner into the practice I was practicing in, and I pulled her in and I said, hey, I want you to come take a look at this patient. This is a patient that has such and such and such. And have you ever seen this? She goes, no. Thanks for, teaching me. And the doctor called me aside and said, she's a nurse practitioner. Why are you teaching her? I said, because she's part of my team. When I'm not here, she's going to see my patient. I want the best care for my patient. So I want to show that, hey, you need to come up to know as much as I know, because that's what we want to do. We want to deliver quality health care. And I'm really taken back when we get the preceptors that take our students to come back and tell me they're doing a great job. I've had physicians that said, this person knows more than what I did when I was finishing medical school. It's the dedication that goes into it, and it's the best education they'll get for their tuition dollar.
You said that a lot of the applicants have a medical background, but do you have any that don't come from a medical background in the class?
Yes, we have several that don't have any medical background. And, we do studies, and there's no study that says that people that do not have medical background are better clinicians. It's just once you get in the program, how much do you want it? How much do you want to learn? How much dedication do you want to put in? Yeah. Question?
What's the length of the PA program?
The length of the PA program in our program is 28 months, a little over 2 years. You cannot work when you're in this program. You basically are devoted to it. We have class from 8 to 4 every day, and then you go home and study another 24 hours. We say eating and sleeping are optional. Okay. The nurse practitioner program that we have here, they basically do a lot of evening classes, and so they allow the students to continue working. So their program is extended to maybe 3 years. Good questions. No more? One more.
What about the certification exam? How long is it?
The certification exam is produced by the same people that produce the USMLEs for the medical schools. It is the toughest program, the toughest exam. It's a 6-hour-long exam. And I tell my students that even though we prepare them well, when they go take that exam, it'll be the hardest exam they've ever taken. And they come back and tell me, I don't know if I pass. But luckily for us, getting to be the number one, I think has been part of that. When we were designated at number one, they have different categories, and our category was in the intelligent. We developed a program, and because we take in a lot of minorities and people from disadvantaged backgrounds, 60% of the student that came through our program were designated disadvantaged. We strive to get as many from the local area, at least 50%. And so my dean comes to me and says, what's the national pass rate? And I go, 92. He says, why aren't you at that level? I said, because I'm like Galveston. I have a lot of minorities in my group, in my cohort. And they said, well, you got to do better than that. So I call on my alma mater, UTMB, because they had the worst pass rate on their USMLE, which is their marker. They had a 14% failure rate. National average was 6.7. They were almost over twice failure rate. And they attributed to they take in a lot of minorities. But they did something that transferred the way that we taught medicine. And they went from passive where the professor sits up here and lectures, to active learning. And we took that concept, we held meetings with them, we took that concept, we trained our faculty to become more, develop the TBL, the flipped classroom. But that put a lot of emphasis, more responsibility on the students. So when they come to class, now we don't lecture, but maybe give them a 15-minute TED Talk on the pearls. But we give them into groups, and we develop cases for them. And they get 20 minutes to solve the case. And then we spend another 15 minutes going over the case. So we developed their critical thinking skills. Our pass rate went from the low 80s to 98%. And we held it for a couple of years. And then COVID hit. COVID hit, everybody took a hit. We included. And so we're having to come back and say, we've done the research. Our students were doing excellent before COVID. We transitioned to online. We saw it dropped. The number of A's in classes were dropping to B's. The number of B's were dropping to C's. And then when they took their last pass rate, they dropped. They dropped to 85%. That scared us. So now we started introducing back the phase line. Right now, our pass rate for this class that just graduated is at 96%. So we know we're doing it right again. But that's a challenge for you guys. You're out there in the trenches. You're the ones that need to prepare the students for the next step. And I congratulate all of you guys for being here, because that means that you're interested. And again, if I had you guys telling me what direction to take, then that helped me a lot. Otherwise I'd be an oceanographer. Why are the programs so difficult to get in? One is because if we look at our admission committee, they always fight me into saying that, why should I accept somebody with the 3.2 when I have 200 with the 3.8 or higher? Why should I overlook those?
I guess that's my question, because this has been I graduated a little time ago, and I remember looking into the office when I went to deciding what I wanted to do. And I'm from Zapata, so we go towards the Laredo area, and the nursing and all these prereqs that to get into, and like, wow, okay, they were only, I remember they were only taking 30 or 35 per cohort I think every once a year. I don't remember exactly, like I said, it's a little over 2 years ago. But they've always looked at all the medical nursing, and that it's difficult. And you said earlier, a 3.8 and a 3.2. I'm a firm believer that I can get 100, she can get 100, I can get a 70, but the job is going to be basically equal or better at times, depending on how much I want to put into it. I don't know if that makes sense, but it's just, that the need is so high, yet the amount of applicants, you said 2,000, we only take about 100, how and then we tell me about it, so.
Well, we always are constantly looking at our numbers, and anybody that knows me will tell you that my priority is to recruit locally, to train locally, and hopefully they can train locally. When we started the program, we had 6 PAs in the valley, from Brownsville to Rio Grande City. Right now, we have close to 600 PAs. 98% of those come from our program. So we've done a great job, and it's time for me to retire. So, thank you guys. Any other questions before I leave? Thank you for your attention.